On today's podcast, we're discussing the topic of joint replacement surgery. You know, it used to be a procedure mainly for people in their 60s and 70s, even 80s, but not anymore. Our guest today is Dr. Ajai Cadambi, a fellowship-trained adult orthopedic surgeon on the medical staff at Texas Health Southwest Fort Worth and Texas Health Hospital Clearfork. He'll talk, among other things, about why younger patients are now having the procedure. He'll also touch on joint replacement technology. And that's coming up next.
Welcome to the Wellbeing DFW podcast. Each week, Scott Sams will cover a different topic on improving health and well-being in our North Texas communities. He will host interviews with physicians on the medical staff of Texas Health Hospitals.
Hi, I'm Scott Sams. Thanks for joining us today. According to the American Academy of Orthopedic Surgeons, joint replacement surgery saw a tremendous increase starting about a decade ago, a 188% increase in knee replacements, and a 123% increase in hip replacements for patients from the age of 45 to 64. And it's likely these numbers have gone up even more. So why the increase in joint replacement in a younger demographic? Well, our guest today is here to talk about that. His name is Dr. Ajai Cadambi. He's a fellowship-trained adult orthopedic surgeon on the medical staff at Texas Health Southwest Fort Worth and Texas Health Hospital Clearfork. Doctor, thanks for being with us today.
Nice to be here. Thank you.
Let's talk about these stats for a few minutes, if you don't mind. Are we really seeing a younger demographic looking for joint replacements?
Yeah, we're seeing a definite shift towards younger patients. Statistically, we do about 900,000 total hips a year in the United States, and about 900,000 total knee replacements a year, and about 400,000 total hips. And that number is increasing, and the projections are by 2030 they're going to be 4 million people. And in that demographic of those 4 million people, more than half of them are going to be less than 65 years old, both the hips and the knees.
And this is something that's relatively new, right?
Right. Yeah, that shift is occurring. You know, the baby boomer generation about 10 years ago, the first wave started hitting 65. So you got all those active people from the baby boomer generation that are now coming through. And that volume is driving the increase in, numbers of total joints. And I think some of the younger patients are seeing the successes with that, and I think it's just a drift downwards to that younger demographic on top of it.
Sure. They see that it's working for their friends or family members, and they say, you know what, I'm not all that afraid about it.
Exactly.
Okay. How much does an active lifestyle play into this kind of trend?
Well, I think, the more active you are, the more wear you put on your joints. So, there's contact sports that can cause, problems in kids when they're younger, collegiate high school athletes that 20, 30 years down the road, you see the side effects of an old meniscal injury or an ACL tear, things that football, soccer players, contact, twisting type sports, tennis players, court sports. You take that into account. Plus, we have a kind of shift, unfortunately, more heavy-set patients. There's a problem with obesity in this country, and the wear on people's joints from being overweight is kind of taking its toll on folks.
And that can cause a real problem, that extra weight. How many medical procedures have become less invasive over the years? Do you think that this has played a role in its increased use in younger patients? In other words, somebody who was in their 40s or 50s 10, 15 years ago, the procedure itself was harder. Now the technology is better. Do you think that's another reason you're seeing more patients?
We as a society are kind of enamored with technology, so we have a more accurate means of doing the surgery in terms of aligning someone's leg up if they're bow-legged or knock-kneed. There's, navigation and computers and robots. So, the younger crowd, the millennials and the Gen X type demographics, certainly interested in that. The recovery from a total joint replacement has been shortened significantly in terms of the hospital stay. Typically, a few years ago, you'd spend 3 or 4 days in the hospital. Now, we can almost do this as an outpatient procedure.
That's amazing.
And, our average length of stay at our facility here is like 1.2 days. This is based on several thousand patients we do annually. So we're getting people in, and they are comfortable enough to go home. We're not pushing someone out of the hospital prematurely, but anesthesia, nerve blocks, the manner in which the surgery is done has made it so they get up the same day. You're not laying in bed for 2 days. You get up the night of the surgery, you're walking down the hall, and the next day by lunch, you're going home.
So the increase in the technology, the increase in pain management is giving these patients more confidence to go ahead and do this.
Yes, and you discussed this preoperatively, and I think you have to have a good mindset when you enter into this type of surgery. It's a lot of motivation, a lot of rehab. So someone who's, I guess the word is hardy or well-adjusted, is going to do well because they already believe they're going to do well, and they've been kind of talked to about what to expect, so they buy into it, which you have to. It's a 50-50 proposition. The patient has to engage in their own health care.
Sure.
And so if you get someone like that who's driven and motivated and believes that that's the way it's going to go, that's the way it does go.
Whether they're in their 40s, 50s, or 70s or 80s.
Exactly. We send folks home in that age demographic the next day also. There's a lot of research out there about early discharge from the hospital, and the intuitive thing would say, well, they sent them home too soon and they're at risk for having a problem and getting readmitted, but the data does not bear that out. Staying in the hospital excessively is probably not good, in terms of exposure to resistant organisms, bacteria, and things. Your safest place is your own home.
My mother-in-law had an aneurysm taken out of her brain down at UT Southwestern in Dallas. They had her out the next day.
Exactly.
Because there were so many people there with the flu, the doctor said, okay, get out.
We have an unusual situation here at the facility we're at. We only do joint replacements, and patients are all been, evaluated from a medical and cardiac standpoint. Whatever their issues are tuned up maximally before we do surgery, but we don't, have a sick patient population here. We have a different type of facility, but still, I think it's good to go on home if you can.
Yeah. Let me ask you, is there a huge difference between somebody in their 40s and 50s getting the same procedure as someone in their 70s and 80s?
Yes, I think they're going to get up and move a little bit quicker. And, those are the patients that ultimately are going to be done in an outpatient environment where they have the surgery in the morning and probably go home that evening with a nerve block in their leg. We have pumps that we can, leave a little tiny catheter like they have done in shoulders and other joints of the body. And you go home with a nerve block that blocks kind of the front of your knee where the incision is.
Yeah.
Those folks are very comfortable. And you can leave it in for 96 hours.
Wow.
That might have been the 4 days you'd had to lay in a hospital, taking pain pills and narcotics and things. And it cuts down significantly on the consumption of narcotics, which is another whole kettle of fish in terms of the issues we have in this country with narcotics.
Right.
So if you can cut down on the volume of narcotics a patient needs, that's a massive benefit. They have less side effects with nausea, constipation, all the other collateral issues of taking a lot of narcotics.
Sure. And also, I would think that would go back to the confidence thing too, because if you're going to be able to get out within 1.2 days is your average,
right?
You're going to be able to relax more at home than you are in a hospital bed with all the stuff going around all the hospital. That's also going to not only relax, but it's going to help you recover quicker.
I think so. The hospital, you got people checking on you in the middle of the night. It's pretty disruptive.
Yeah.
You're going to sleep better at home, and you're going to have your comfort of your own family members there. And you have to have, this is something you have to look at when you get someone ready for surgery, is that they got a teammate. They got someone there. You can't go alone on this.
Right.
You can't drive for a couple of weeks probably after a hip or knee replacement, so you need a little bit of help. But it's not 24-hour monitoring. You can go home and get up and go to the bathroom and go fix yourself a sandwich probably after one of these.
That's great.
Procedures. That's great. Your mobility is not that hamstrung.
Right, because of the new technology and the new ways you're able to help them. Let's say someone is listening. There's a man or woman listening to this podcast right now, and they are 47 years old. What are the benefits for someone who's 47, 48, 49 years old of getting the replacement done at this age compared to getting this done 20 years later?
You want to, in that individual, and I saw a 41-year-old girl today that needs her knees replaced. I see this all the time. Oh. The shift has kind of come that way, especially, in this community here for whatever reason. I think we have a younger demographic than, say, a retirement community in Florida or something like that. But in terms of that young 49-year-old person, well, you want to make sure they've exhausted all the conservative measures first. You don't just say, okay, let's just go do the surgery.
If you try to come up with something.
If they've had arthroscopic surgery and now they're bone on bone, whatever the pathway was, they might have rheumatoid arthritis and there's nothing else to do. Inflammatory arthritic process, or they had a traumatic injury caused all the loss of cartilage where they're bone on bone. But perhaps they've tried injections. patients will go get different types of injections with lubrication shots. There's PRP injections, which is, they take some blood out of your arm and spin out the platelets and inject that back. That has an anti-inflammatory effect also, but it doesn't always work. If you're bone on bone, you got a problem that's probably not fixable with this because it's simple physics. You have no cushion left in your joint. It's like a tire that's lost all its tread.
Yeah.
So that person, when it comes down to the nitty-gritty of making a decision of a joint replacement, then you have to look at quality of life. And if they're having more bad days than good days, they have pain at night, loss of work time. That the economic loss of someone who is not able to do their job because they're crippled that badly. Probably the benefit is to do the operation with the understanding because they're young, they might face a redo at some point down the road. It's probably, this is a whole discussion about, the rate of revision and redo surgery is going to be higher in younger folks.
Just because you're going to be using the replacement longer.
The studies have shown that the economic benefit is there from someone being gainfully employed again, right? You're a GM guy and you're on the assembly line and now you can't work. Well, you've just taken a guy that's contributing to society, he's got a job, he's paying taxes, and now he's disabled. And you tell him, well, come back in 18 years if you're 47, come back when you're 65. That's unreasonable. And I always tell my patients they need to weigh the benefits of being fixed now and having a good interval of pain-free years with the possibility of the thing wearing out down the road.
Right. And then you can address it again.
Right, yeah.
But in the meantime, you're going to have these productive years.
Exactly. So, that's the kind of discussions I have with folks. They're either been told by their physicians they're too young or they feel that they're too young. And, I'm not trying to twist their arm into the procedure, but I have to we give advice and then people have to make their own, decision based on informed consent is what we call it in medicine,
Any drawbacks to getting it at a younger age?
The wear. I think the issue potential is that, you're putting millions of cycles, bending and straightening out, say, a knee, just living your life on an annual basis over 1 million times, it's going to bend and straighten out. And that's, if you took a doorknob and twisted it that many times over the course of time, it's going to wear out.
Right.
And the same thing goes with a hinge in your knee or a ball and socket joint in your hip. And typically the wear is going to be the plastic piece in there is going to start wearing, and you might have to go back in and partially redo it. It's like putting a new brake pad in a car.
Right.
It's worn down.
Right.
Sometimes the parts might come loose from the bone over time, dislodge, and you have to redo more. Mm-hmm. So it gets more complicated. It's a case-by-case basis.
If I'm going to have a knee that has to be done, how long is that knee replacement going to last?
Typically, a total hip or a total knee will last 20 years in 90% of the population. You're going to have 10% of folks across the board are probably going to not make the 20th year. So if you're dealing with a 75-year-old person, you're probably talking about it's going to last the end of their life.
Yeah.
But the 40-year-old person, 45-year-old person, they're statistically probably going to need a revision. And the risk of revision is about 30% in that 50 to 55-year age group, and it's about 5% if you're 70 or older. So, it's how much life do you have left versus how much life the implant has left.
Right. It's lifestyle and
yes, and what are you doing? So, I have to kind of readjust people's expectations sometimes because they think they can run or jog or do some sort of impact type exercises on an implant. And that's not a good idea because that'll accelerate the wear.
Sure.
An elliptical is better than jogging or a bike or something else. You have to redirect people into healthy activities that are not going to
mess up the process.
Yeah, right. And there's gray zone activities. People are avid skiers. Well, you got to be a little bit careful that you don't tear a ligament when you have an implant in place because it's a totally different problem than tearing a ligament if you got your intact knee. Things like that. There's certain things that are kind of gray zones that, if they do it in moderation, it's probably not going to hurt the device. I take care of a lot of people that are Western lifestyle type patients, my association with the rodeo here in Fort Worth, and I get a lot of ex-rodeo guys that are, bull riders and stuff that are in their 40s and 50s that are bone on bone.
Right.
And they want to go back to team roping and things like that, and there's absolutely no reason you can't get on a horse and ride around. It's no different than sitting on a motorbike or doing anything else.
Sure.
So I get those guys back up and running, and they still get to go out and be ranchers and cattlemen and competing, but you're not going to go back to riding bulls or bulldogging or something.
You're not going to have those 8 seconds of glory.
Right, but those guys, they've been injured so many times. It's 100% injury rate in that crowd.
Right.
So I take care of those guys, and they're very thankful, and they get back to being functional, and they get to ride a horse still and do work the farms.
Really
yes, right. So you have to kind of set realistic expectations with your patient.
Let's do a hypothetical here quickly. A runner, let's say a woman, she's 54 years old, and she's had knee issues since she was in high school. She was a high school runner, and all these years, then she went through and she had her family. The family starts growing. She gets back out and she starts running again. Still has the same issues.
Yeah, you have to determine what the problem is. It could be anything from a soft tissue problem that's not needing surgery, a malalignment, and maybe needs some sort of a kinesiotherapy or physical therapy to sort it out. If it's been that long standing, then you wonder if it's arthritis or not, and you have to establish a diagnosis. That's the first thing you do with a patient is determine what's going on and try conservative treatment first. And then say the patient is bone on bone. Then you're going to have a frank discussion about, running is going to always hurt because you're bone on bone.
Right.
And if I do a knee replacement, well, your pain will go away. And the real goal of a joint replacement is to be able to walk and get around without hurting.
Yeah.
And so you have to kind of shift the expectation. A lot of folks are disappointed to hear that, and I understand it. I was a marathon runner, bike racer, and you get a little bit older, you can't pursue those things for whatever reason, but you want to encourage people to stay active, but you don't want them to try to, run a 10K on an artificial knee or hip. That's not a good idea in my opinion.
It's not what they're built for.
No, and they've done polls. The American Hip and Knee Society, our professional group, puts out these questionnaires to all of us and asks what do we allow and what we not allow. And it seems to be pretty much
pretty uniform,
unanimous that impact exercise is not a good idea.
Yeah.
So trying to get someone redirected sometimes is difficult.
Do you see more men or women in your practice?
It's 50-50, I think. It depends what the diagnosis is. Women have a lot more inflammatory arthritis. So if you're a guy that gets referred from rheumatologists, you might only see women patients because rheumatoid arthritis and lupus are more in women than men. The demographics are, in my practice, are pretty close to 50-50. I think women tend to wait longer.
Really? See, I was going to
know that statistics, and I just read about this. They tend to wait longer to present
the issue.
Maybe they can tolerate pain better, or they're just
definitely
more
stronger.
Yeah, I mean, there might be a generalized fear of the procedure or the pain associated with it, which has been really modified with all the techniques we use now. And maybe a little bit more women than men get total knees demographically when you look at studies and papers that we read, research, but it tends to be even on the hip side, on total hips. So it's probably 50-50.
When you said that really surprised me because, you hear all the time that men absolutely won't go to the doctor, that their wives or their partners have to tell them to go to the doctor.
Yeah, I see that. I see that sometimes. The guy's there and he's kind of, I don't know why I'm here. And the wife kicks him and says, you tell him the truth now. And you look at the x-rays and it's horrible and they need to be fixed.
Yeah.
So, there's a component of that.
That's something.
There's also, cultural components. Certain ethnicities tend to present to the doctor faster than others. And some folks are just generally fearful of going to the hospital. They equate that with the end of life rather than getting fixed.
Yeah.
So there's a component of that sometimes that it culturally exists.
When a patient comes into you, you're not going to say, okay, grab their arm and take them into the OR. You're not going to do that. Do you find that when a patient first comes in, they're kind of scared, because they don't know, they fear the unknown. And then you get to all these different steps you want to take them through, and you tell them all the steps you want to take them through. Do you find after the first couple of steps, they're on board, they're ready to go?
Yeah, I think so. People have a generalized anxiety going to the doctor, and you have to, just alleviate that and make them feel comfortable. And we throw a lot of love at our patients, whether it's my nurse or my physician's assistant or the medical assistant. You want to make them comfortable. And then you just have to get down to, speaking the truth. And if there's somebody's knee is crooked 30 degrees and it's completely bone on bone, there's a lot of missing stuff, you probably need to have the discussion about surgery a lot quicker than somebody who's got a little bit of arthritis that you can probably try some injections, some therapy, things like that, a brace maybe. There's a whole gamut of things we can do before we start talking surgery. But ultimately, if none of that works, then you might have a visit with them several times.
Yeah,
I have patients I've followed for years before they had surgery. Huh. They come in every 6 months, take an injection. How you doing? Get an X-ray a year later. Well, it doesn't look much worse than it did a year ago, so we're going to keep watching you. Then you have the elderly patient who's been kind of holding off for too long, and your problem with that person is if you're 75 and you wait till you're 80 and they have an obviously bad joint, you're not going to be healthier.
Right.
So I'm not trying to convince them to go have a surgery. They have to make their own decision. But the reality is the older we get, the less healthier we get. We're less mobile. Aging creeps in. So there is a kind of a sweet spot where you want to fix somebody.
Right. Get it done.
Yes. Yeah.
Get it done now.
Right.
What would you tell the person who's listening to us right now? What would you tell them if they've got a knee that just is bothering them like crazy, or they've been walking with a limp because of a hip? What are you going to tell them to do right now?
I think, you need to get a qualified opinion and analysis of the situation, establish a diagnosis, and that involves going to someone who is a specialist in that area. Typically, patients come to us either from word of mouth, and it's anything from they're in the checkout line at Walmart and another person says, you're limping, here's the doctor I'd use.
Right.
Or they're getting their hair done or whatever. They're in bridge club in a retirement community or something.
Right.
But then you have primary care doctors. So they might end up going to their primary care doctor, gets an x-ray, and it looks bad. So now you need to go see these guys over here in my group of 7 guys. So once it gets down to that, you really need to look at the physician's experience. This is what they do day to day. The facility, if you're going to end up having surgery, you need to go to a place that does a lot of something. The statistics has borne that out with heart surgery or joint replacement. A high volume place has a tighter bell-shaped curve of outcomes. You're not going to have as many outliers because you're doing the same thing over and over. The whole staff is versed on how to do that stuff. So
and you do that here?
Yes, at Texas Health Clearfork. Yeah, so we did 3,200 joint replacements last year.
That's amazing.
So, it's not a factory. We treat everybody individually.
Sure.
And a lot of TLC and, from the admissions process all the way to going home. But, you have to look at the facility and you have to look at what is the infection rate and the complication rate. And that data is out there. But, ours is very low. We have metrics and we have been in this facility, I think, probably done 10,000 cases here in the last 3 years, I bet. Texas Health has that data.
Yeah.
Here at Texas Health Clearfork, we're part of Texas Health Southwest, and we only do hip and knee replacements here. We have a program that has now gotten to well over 3,000 joint replacements a year at the Texas Health Clearfork facility, and everything's geared towards that. From the preoperative admissions all the way to discharge, our ORs are all geared to doing hip and knee replacements at the Clearfork facility. A patient thinking about getting a hip or knee replacement, they need to realize it's a team effort, that they're part of the process, not a passive vehicle through it. And if there are any modifying things that can be modified, say they're overweight, they need to lose some weight. Maybe their diabetes is out of control, they need better, tighter control, because these things are all risk factors to the outcome. If you have some outlying factors like that, it could make it higher risk. So we want to minimize risk and optimize the patient.
Right.
So those are things that, this is well past just my knee hurts. But if you get down that road, these are all the discussions we have with patients.
And they should come see you.
Right. They have to come see us to start the process.
Right.
You can go to the internet and read a lot, but you ultimately have to go see a doctor. And, asking questions is good. I bring a list of questions. I don't mind sitting there and answering 20 questions. My nurse, myself, my PA, we go through this process to make the person comfortable.
Yeah, because that's the end result. That's what you want.
Right.
You want to make that person comfortable.
Right, exactly.
All the time. Doctor, I don't think I've ever heard of anything called joint camp, but you have joint camp here.
Yes, anybody that's going to go through having the surgery is given the opportunity to attend a class, basically, that goes over all the facets of what to expect and what's going to happen. So they don't come into this cold with any surprises. The nursing staff, the therapy folks, all talk to them about what to expect. And it makes for a smoother sort of experience because there are no surprises. You've been told you're going to have X, Y, and Z done at this point in time during the stay. And patients really like it. They like being engaged in that process and learning.
Well, sure. And it gives them more confidence, which helps you help them even more.
Exactly. A lot of their questions are answered. They answer questions at the office, then they're answered at their pre-op visit, and then in the joint camp, they get to ask the question again and get it answered. So numerous touch points along the way, getting a patient educated so they know what to expect.
Information is so key.
Exactly.
In everything we do. So there's no archery, no canoeing.
No, nothing like that. It's more, kind of a learning process.
Doctor, when a patient has surgery, as you mentioned before, it's kind of almost a team sport thing here as far as the recovery goes. Like if my wife had to have knee replacement surgery, I would want to know, how can I make sure that I take care of her without hurting her? Is there something that you can do to help me as the spouse help my wife better?
Exactly. There's a little bit of anxiety on the partner who's not having the operation, worrying about taking their spouse home and what ifs and things like that. So there is actually the day after surgery, a little class that the patient's family member, you need a teammate like we talked about earlier, can attend and learn what to do, whether it's, with a hip replacement, there are different precautions than a knee replacement, and, the medications that they're taking. It circumvents a lot of problems and, anxiety and maybe even phone calls, afterwards when they go home, if they're informed on the front end about and taught.
Taught what they can do and what they shouldn't do.
Right, exactly.
Is that exclusive to this group?
I'm sure programs have this sort of, part of the process out there. There are a lot of major joint replacement programs, but I think it's an important part of it. I can't say we're the only people that do it, but it is nice to have it.
Yeah, it's the first I've heard of it. I think it's great. Doctor, thank you. That's going to do it for today. I'd like to thank Dr. Cadambi for joining us. We do appreciate it. Texas Health is partnering with you for a better North Texas. To hear more Wellbeing DFW podcasts, just visit our website at texashealth.org/podcast. I'm Scott Sams. Thanks for being with us.